Can I go ahead? Hi, so I'm Debs Gardner. I'm the Maternal Mortality Review Coordinator here at the Washington State Department of Health, presenting today from rural Kitsap County on Suquamish land. And we're going to be talking about the new Maternal Mortality Review Panel report that came out in December 2025. So the vision and implications, the place that we're coming from in doing this work is that any maternal death is unacceptable and that ultimately we hope to prevent deaths to address inequities that drive them and just improve well-being of adults and children all over Washington state. I'm going to give a little bit of background about the Maternal Mortality Review Panel, or MMRP, for those who may not be familiar with it or who would like a refresher. To put our work in the context of national work, maternal mortality review happens nationwide and actually has been in some form or another going on for a long time. And in the last decade or so, really ramped up in connection with work that the CDC is doing. This map comes from CDC, and the dark blue states and jurisdictions here are those that are doing maternal mortality review funded by CDC. There are a couple that are lighter blue that are currently doing maternal mortality review not funded by CDC. And then you'll notice a couple in gray that are not currently doing maternal mortality review. Texas stands out as the only of the states that is not doing it. This does fluctuate. Texas did actually do maternal mortality review until a couple years ago. Idaho was briefly not doing it and is doing it again. All the states learn from each other. We do things a little bit differently, which is something to keep in mind when Annie is talking about our data in a few minutes. In Washington, our maternal mortality review panel was established by the legislature in 2016. There's the RCW on the screen, the law that oversees our work. And in 2019, that law was amended to make the panel permanent and to add some details about the panel structure and process. And basically, this law directs the MMRP to review comprehensively every death of a Washington state resident that took place in pregnancy or up to 1 year after pregnancy. And then it also does some things like gives DOH the ability to get the kinds of medical and other records that we need behind the scenes to prepare the panel to do these reviews. The MMRP is hosted at the Department of Health, and it is actually the largest in the country. We've got about 101 members on it currently. Not everybody comes to every review meeting, but we have just an enormous breadth and wealth of expertise and backgrounds, which includes a priority focus on American Indian and Alaska Native communities. And then this panel does the work as described in the law that I mentioned, reviewing anonymized, de-identified summary of every death of a Washington resident in pregnancy through 1 year postpartum, and gives a report to the legislature about every 3 years. I mentioned that wealth of experience, and this is just a small sampling of that expertise, everything from Indigenous lactation counseling, maternal fetal medicine, substance use disorder, tribal health, lived experience, medical transport, the list goes on. Almost everybody on the panel has more than one type of expertise area and or lived experience. And we're frankly very lucky in Washington to have this panel. Our review process overall, DOH will identify and confirm the deaths, and then requesting the medical and other records to write that de-identified summary the panel uses to review the deaths. And then the MMRP meets to review the deaths and make recommendations for prevention. And then every 3 years, as we gear up for the report, the MMRP and DOH do a lot of work to consolidate and narrow down recommendations and look at the data and compile those data and recommendations into the report we're talking about today. I'm going to touch on a couple definitions because they're going to help the findings make more sense and to understand a little bit about that process. So sometimes we refer to pregnancy-associated deaths. That is just a time period designation. That is literally all deaths from any cause that happen to take place during pregnancy or up to 1 year after the end of pregnancy, regardless of whether they were related to pregnancy. So a subset of that, some of those pregnancy-associated deaths, the panel determines are pregnancy-related, caused or worsened by pregnancy. And this could be things that might be fairly obvious, like a pregnancy complication or a chain of events initiated by pregnancy. But it actually also includes things like an unrelated condition that was aggravated in some way by some aspect of pregnancy or postpartum. Some of the deaths, the pregnancy-associated deaths, the panel finds are not pregnancy-related. And then for some, the panel determines they don't have enough information to determine whether the death was related to pregnancy. And so when they meet to review these cases, first of all, they do this very respectfully. And each potentially pregnancy-related death, they spend up to an hour discussing it. Was the death pregnancy related using those definitions I mentioned? And if so, was it preventable? And in Washington, we don't just ask whether it was preventable from, a clinical medical perspective, but also an equity or social determinants of health perspective. They ask questions like whether racism, discrimination, and bias played a role. That includes structural racism, that includes bias about substance use disorder. They ask what factors contributed to those pregnancy-related preventable deaths. And for those deaths, they make recommendations. What types of interventions or systems changes might help prevent such a death, either at the time or even upstream years before? And those recommendations, again, become the basis for the ones in the report every 3 years that we'll be talking about. A little bit of context about the report before Annie goes into the data section. So we submitted this report to the legislature in December. It was the fourth of these reports to date. The aims of the report were preventing maternal deaths, raising awareness, promoting change, increasing health equity, and improving care. The report covers data from 2021 and 2022 maternal deaths and some cumulative findings back through 2014. There's recommendations for the legislature and other audiences, and there's an addendum from the American Indian Health Commission that you'll be hearing about from Cindy and Jan Marie in just a little bit. For those who are familiar with our last report, a couple changes. This one is a bit shorter and more focused, particularly on that legislative audience. We separated out the legislative recommendations and put them first. We include storytelling, including some voices from Washington about pregnancy, birth, or postpartum experiences and challenges, and also some success stories about implementing recommendations from the past report, the 2023 one. And in a moment, I can put the link to the report in the chat if it's not there already, but there's a QR code for it here as well. And now I'm going to turn it over to Annie to talk about the detailed data and findings from the report.
Thanks, Debs. And I'll just ask for next slide when I need it. So before we dive in, there's a few important considerations to keep in mind. First, maternal mortality is a relatively rare event. This means we're often working with small numbers, which can make rates unstable, especially when broken down by specific demographic groups. Additionally, Washington state maternal mortality data is not generalizable and should only be interpreted within the context of our state. That being said, even with these limitations, we can still utilize maternal mortality data to identify patterns and make meaningful recommendations and interventions. Next slide. So the United States has the highest maternal mortality rate among wealthy countries. In the next few slides, I'll provide the national and state level rates, but I won't be showing them together because I just mentioned that national definition of pregnancy-related deaths differs from Washington's definition. The key difference is the national rate doesn't include injury deaths such as homicide, suicide, and accidental deaths, which include overdose. Next slide. Here we have the national rates of the pregnancy-related mortality from the Pregnancy Mortality Surveillance System, which is otherwise known as PMSS. We can see a noticeable increase in maternal mortality rates during 2020 through 2022 compared to previous years. Research has linked the rise experienced in 2020 and 2021 primarily to the COVID-19 pandemic. The increase is not only driven by the direct impact of the virus, but by COVID-19 exacerbating existing health conditions and disrupting access to healthcare. Although it's not shown on this slide, the national maternal mortality data also highlight disparities by race, ethnicity, and age. Next slide. Here we have the Washington state rates from 2014 through 2022. As we defined earlier in the presentation, pregnancy-associated deaths is a broad overarching category that includes any death occurring during pregnancy or within 1 year after pregnancy. So that's the dark blue line, and it's a culmination of the accumulation of both the pregnancy-related death, which is the light green dashed line, and the pregnancy-associated but not related deaths, which is the light blue dashed line. Washington's pregnancy-related maternal mortality peaked in 2021 at 33.4 deaths per 100,000 live births, followed by 27.6 in 2022. These are the highest rates observed in the 2014 through 2022 period. This increase in pregnancy-related maternal mortality is likely due to several factors. First, a rise in overdose deaths, particularly involving fentanyl, which has become more prevalent and deadly. Second, deaths related to COVID-19. And finally, the Maternal Mortality Review Panel has continued to evolve their process for deciding on pregnancy relatedness, which can impact the number of pregnancy related deaths identified. Next slide. So here we're going to take a closer look at maternal deaths in Washington in 2021 and 2022. For those years, we identified 107 pregnancy-associated deaths. And in the second row of this chart, starting from the right, you can see that 46 of the 107 pregnancy-associated deaths were determined not to be related to pregnancy. For 10 cases, it could not be determined, and that leaves 51 deaths that the Maternal Mortality Review Panel determined to be pregnancy-related. Finally, the panel also assesses whether the pregnancy-related death is preventable, and of those 51 pregnancy-related deaths, 42 were considered to be preventable. Next slide. So as we just saw on the last slide, the panel found that 82% of pregnancy-related deaths were preventable, meaning that at least some chance of the death, there was at least some chance of the death being averted by, if a clinical equity or social determinants factor that contributed to the death had been different. 82% is very high. However, this means we understand preventability and can take action. Next slide. Inequities and disparities persist in pregnancy-related deaths in Washington. In the next slides, I'll provide cumulative findings from 2014 through 2022 and discuss how, depending on age, race, and ethnicity, geography, and insurance status, the rate of maternal mortality differs. Next slide. The graph on this slide and in the following demographic breakdowns that I'll go through will provide the frequency of pregnancy-related deaths in dark blue, which is the actual burden or volume of pregnancy-related deaths, and rates in light blue, which is the frequency relative to the size of the population or subgroup, allowing for comparison between groups of different sizes. The rates include confidence intervals, which is important because the confidence interval quantifies the uncertainty around these estimates. Additionally, if a subgroup is marked with an asterisk, it means that the rate has a relative standard error that is greater than 25% of the rate itself, which indicates the estimate is statistically unstable and should be interpreted with caution. So for this breakdown, we can see that pregnancy-related mortality occurred most frequently among individuals aged 30 to 34, followed by those aged 35 to 39. Although individuals aged 40 and older had the fewest pregnancy-related deaths in terms of absolute numbers, they experienced the highest maternal mortality rate, which reflects the fact that while fewer people in this age group give birth and fewer die overall, their risk of dying from pregnancy-related death is disproportionately high. These findings highlight the risk for pregnancy-related deaths increases with age, especially for those over 40. Next slide. Non-Hispanic American, Indian, Alaska Native people experience higher maternal mortality rates than any other racial or ethnic group. Although the absolute number of pregnancy-related deaths is low, their risk of dying from pregnancy-related causes is 7.3 times higher than that of non-Hispanic white people, which reflects an alarming disparity and is why we have an addendum to the report from the American Indian Health Commission, which you'll hear about after this presentation. Additionally, non-Hispanic Native Hawaiian Pacific Islanders, non-Hispanic Black, and non-Hispanic multiracial individuals experience high rates of pregnancy-related mortality. Next slide. When we look at pregnancy-related mortality by an individual's primary insurance, people with Medicaid experience both the highest number of pregnancy-related deaths and the highest mortality rate at 36 per 100,000 live births. These figures highlight the critical importance of ensuring access to quality care and support through the perinatal period for individuals covered by Medicaid. Next slide. Lastly, we'll look at pregnancy-related mortality by rural urban residents. Although 122 pregnancy-related deaths occurred among people living in urban areas, the overall mortality rate was highest among those living in rural areas at 26 per 100,000 live births. This underscores the importance of improving access to quality maternal health services in rural communities. Next slide. So now that we've looked at how pregnancy-related mortality varies across different demographic groups, let's shift our focus to understand why these deaths occurred. We'll explore causes, timing, and contributing factors behind pregnancy-related deaths, and this will help us see a bigger picture of the challenges faced and where interventions might make the greatest impact. Next slide. Looking at pregnancy-related deaths from 2021 and 2022, the top 5 leading causes of pregnancy-related deaths were accidental overdose, COVID-19, suicide, cardiovascular conditions, including peripartum cardiomyopathy, and also thrombotic embolism. These causes highlight a mix of clinical, mental health, and social challenges that contribute to pregnancy-related mortality, underscoring the need for comprehensive approaches to prevention and care. Next slide. Most pregnancy-related deaths occur within 43 days to 1 year postpartum, followed by deaths within 42 days of pregnancy. These findings underscore the importance of care, support, and health insurance coverage through 1 year postpartum. Next slide. So the panel identifies those contributing factors that led to each preventable pregnancy-related death. These factors are defined by the CDC and are the events or circumstances that, if different, the panel believes the death might have been prevented. The graph on the left represents the top 12 contributing factors. I'm going to quickly highlight the top 3, which were lack of continuity of care and/or care coordination, lack of access to care or financial resources, and clinical skill or quality of care. For each identified factor, the panel makes recommendations to prevent future deaths. Those recommendations are going to be discussed by Debs in the next part of this presentation. Next slide. Quickly, before we move on to recommendations, it's important to highlight the panel found that discrimination, bias, and interpersonal racism or structural racism played a role in 76% of preventable pregnancy-related deaths from 2021 to 2022. These findings emphasize the need to center Black, Indigenous, and other communities of color as leaders in the successful implementation of many of the recommendations shared in this presentation and in the full report. And with that, I'll hand it back to Debs to go over the recommendations.
Thank you so much, Annie. So let's delve into those recommendations. I want to talk about the structure of them first. And again, you'll find the link to the report in the chat now. Here's a QR code for it. We organized the recommendations in the report in a couple ways. So there's 3 overarching recommendations that all the others are categorized under. So 3 basically topic areas. And again, we have the legislative recommendations first. I put the page numbers up there for them, and then a separate section with recommendations for other audiences. I emphasize this because it's really easy to miss one or the other. The legislative recommendations, there's only 12 of, but they're very highly detailed. So these are the 3 categories we'll be going over, the 3 priority recommendations. They're basically about healthcare quality and access, community support services, and equitable culturally responsive care. So let's start in with the one about improving healthcare quality and access. So the overall priority recommendation is that we ensure Washingtonians have access to high quality healthcare, including mental health care, substance use disorder treatment, and preventive care throughout pregnancy, birth, and postpartum. And to do this by things like strengthening and funding care coordination, improving communication and protocols, and ensuring providers actually have all of the skills and training and professional support that they need to provide high quality care. So I'm giving you a couple sample recommendations, but there are many, many others in the report. I just pulled out a couple that I thought might be of interest. These 3 samples are all for other audiences, not the legislature, but you can look at the detailed legislative ones as well. So one of them is that hospital systems provide training and develop policies and procedures to ensure that providers and staff, including emergency department and urgent care providers and staff, can recognize, respond to, and manage pregnancy-related emergencies across settings. So for all hospitals that offer emergency services. Another example one is for state and local agencies, healthcare systems, facilities, providers, and community organizations to follow best practices in health communication to counter health misinformation and disinformation about vaccines or other topics relevant to health in pregnancy and postpartum. And another example one for state and local health departments, health systems, healthcare providers, and relevant community organizations to raise awareness about urgent maternal warning signs, perinatal mood and anxiety disorders, and substance use disorder or opioid use disorder in pregnancy through public health messaging strategies and patient education. Our second priority recommendation is about strengthening community support services, and this is investing in developing and expanding comprehensive community support services that address essential needs in pregnancy and postpartum. So things like strengthened home visiting programs, social work services, doula support, and wraparound support for mental health and substance use disorder. So a couple example recommendations I pulled here. Again, these ones are all non-legislative recommendations, and there's many more in the report. So one of them is healthcare providers connecting pregnant patients who are experiencing mental health conditions, substance use disorder, opioid use disorder, or other complicating factors with a harm reduction doula who's trained to coordinate health and social services. Another sample, health systems and facilities integrating peer support into care teams to make it available across the perinatal continuum. And this is particularly important for people with co-occurring physical and behavioral health conditions, including histories of substance use disorder or opioid use disorder and mental health support needs. Another example that DOH and local health departments invest in building healthy and safe communities. So working towards systems level changes to address social, relational, and service gaps, supporting communities in developing more robust early learning, education, childcare, parenting support, healthcare, and economic opportunities. There's also a lot of recommendations in this section about meeting basic needs. So things like housing, for example, and income. Our third priority recommendation is about providing equitable, culturally responsive care. So ensuring that care and services through pregnancy, birth, and postpartum are culturally responsive, free from bias, grounded in trauma-informed practices, and actively address racial injustice. So a couple examples from this. One is for state and local agencies along with community-based organizations to deliver ongoing culturally relevant messaging about how to safely access perinatal care, including for immigrant and refugee communities, including language-specific messages about health insurance access, privacy protections, and opportunities to receive perinatal care and support regardless of insurance or immigration status. Another sample, DOH and healthcare systems funding tribal-led, indigenous-led, and community-led efforts to expand access to prenatal and birthing care in American Indian and Alaska Native communities, including in rural areas. And then also one about healthcare facilities implementing systems that support and deliver patient-centered, trauma-informed care for pregnant and postpartum people experiencing intimate partner violence, domestic violence, or gender-based violence. So again, those are a couple examples of the, over 80 something recommendations in the report. So please look at the report for others that may be relevant to you. But I want to kind of set some and recognize some current context that impacts these, including just current and emerging context and challenges, things that make the recommendations kind of both more challenging to implement and also more important to implement. So, for example, things like Medicaid cuts. Many of us are concerned about that. Medicaid covers 45% of births in Washington, and that's 70% of births in rural areas. So that kind of drives home some of the intersectionality of the demographics you're seeing in Annie's section on data. Rural maternity care shortages, perinatal and reproductive care access challenges and fears around the country that also can impact Washington, mental health care access issues, funding limitations, including state and local budget limitations and just the current funding landscape, misinformation and disinformation, threats to immigrant, BIPOC, and LGBTQ communities and people perceived as parts of those communities, uncertainty about health, environment, and society in the future. We don't know what is coming in terms of social and health, issues. Like we see some things, but we don't know if there's going to be another pandemic or what's going to happen. This is one of the reasons you see in the report, there's recommendations both about protecting existing services and also taking new steps. Some recommendations require funding and some do not. So implementing recommendations in the report, we look at it as both centralized and decentralized. Centralized as in like the legislature doing something statewide or other statewide efforts or State Department of Health efforts or the Washington State Perinatal Collaborative kind of acting as an implementation hub. But there's also decentralized recommendation implementation. Any local or regional effort led by any organization, entity, coalition, or individual on any scale from practice level to regional level, also the work of regional perinatal collaboratives like your own, implementation is very widespread. I want to just call attention to the fact that the report includes storytelling, again, people's personal experiences, but also some success stories. And I just put up on the screen a storytelling example about implementation from a recommendation from the last report about facilities giving birth parents who use or have used opioids or other prescribed substances take home doses of naloxone, and a birthing center looking at the report and deciding to implement that. So all of this is part of implementation. Finally, I want to leave you with a couple of questions, and we're going to come back to this slide after Cindy and Jan Marie's presentation on the addendum from the American Indian Health Commission again. But I'm putting these questions here for you to start thinking about and looking at the recommendations in the report and its addendum, which is at the end of the report, to think about what recommendations are most relevant in your jurisdiction, your community. How can the report's findings and recommendations support your work and priorities? Is there something you're working on that's related to one of the recommendations or that you want to start working on? And if so, who do you want to collaborate with to strengthen the work? Or do you want to be involved in something somebody else is working on? Who else's efforts might you be interested in? So we want to spark some conversation and an opportunity for you all to connect with each other and say, hey, I'm really interested in getting involved in this, or I want to remind folks that this is going on, and how can we work together? So I'm leaving you with these questions. We'll come back to them. I can take a couple of quick clarifying questions before we move on, and then we can have another longer period after Cindy and Jan Marie's presentations for any more in-depth questions for either set of us or discussions of those questions. So any quick clarifying questions for either me or Annie? I see a question there. Nicholas, go ahead.
Yeah, I'm just wondering if there was any correlation or related to perinatal mood and anxiety disorders with the preventable deaths in order to, extract that information out, or is that not possible?
Since we end up looking at cause of death, it's usually the more immediate cause of death. And then the case narratives are discussed by the panel members to identify those contributing factors. So it's not always that we are looking at every diagnosis of each case. It's more thinking about the causes of death in the more immediate terms and then considering kind of the whole landscape of the case as far as those contributing factors identified by the CDC. But we didn't look into like the different types of whether it's depressive disorder or anxiety disorder, any of those things with the suicide deaths because of the small sample size. But that's a really interesting point and something that we can kind of look back at a future time if we look at more years worth of data.
Particularly under the recommendations and how screening is really not very robust in our
Yeah.
systems, including fathers.
So there are recommendations about perinatal mood and anxiety disorders, and that does reflect the cases because, like I said, the recommendations do all come specifically from the cases. So I recommend looking through that. We always have screening recommendations. There is a mention of supporting fathers and other non-birth parents in at least one of the recommendations. And then when we write a new report, The previous report or reports don't become obsolete. The recommendations in each report reflect the cases we've discussed in those years, but often there are recommendations from the report before that haven't been implemented yet and are still relevant. And I know that there are screening recommendations both in the new 2025 report and in the 2023 report. And in any work or advocacy or other efforts anybody is working on, you can point to either of those reports and say, this is something the MMRP has found to be important. So thank you for asking that. Annie, do you want to talk about whether the review looked at infant feeding methods? Do we have data on that?
We don't have data on that. It would, whether something is identified, because we don't do any sort of informant interviews, we're looking mostly at resources from providers, and usually they don't have that level of information in them. But that's really interesting. That's an interesting thing to bring up, because I think sometimes, whether depending on what our panel members' expertise are, they can usually bridge the gap with some of those more specific method-based recommendations, whether we have that information about the case or not.
And I noticed looking through our recommendations, one of the sub-recommendations there's a legislative recommendation for universal access to wraparound services, home visiting, doula support, peer support workers, and it includes a recommendation to invest in culturally appropriate lactation support programs, including home visiting and peer breastfeeding support programs. So that does get recognized in the recommendation work as well. Let's see, I think we might need to time-wise move on to Cindy and Jean Marie's presentation. Is that correct, Jax? And then we can kind of come back and discuss together any either larger questions or spur that group conversation about what recommendations y'all are working on, want to work on, and how you want to collaborate.
That sounds great.
Great, okay. Then Cindy and Jean Marie, I'll turn it over to you.
Thank you, Debs and Annie. Hi, everyone. My name is Cindy Gamble, and I am Tlingit, and I work as a tribal community health consultant with the American Indian Health Commission. Here today with my good friend and colleague, Jan Marie Ward.
Thank you
Okay,
both
I'm just
for
trying to
being
get
here.
the screen there. So can you see the slides?
We can see the slides. We see the creation. So you just need to share there.
There we
You're
go.
good to go. Thank you so much both for being here.
Yes, thank you as well. As Cindy said, we're both here on behalf of the American Indian Health Commission. I'm Jan Marie Ward. I am Sani Inez and Barbareño descendant from California, Mission Indians, and I'm Chumash and have been here for many, many years working with the tribes in Washington State. I just also want to mention that today is Billy Frank Day, and he is a really important ancestor, and certainly throughout the advocacy that he did for many, many years, and he's well known throughout our state and throughout the country for his advocacy and treaty rights. And I just also have to say that, and the environment, but in all of his work, he always mentioned the children, the moms, and the grandmas, and how they connect to food sources, and all of the things that are interconnected and interwoven in our work. So it is relevant to acknowledge him today. I also come to you on the lands of the Nisqually people. So you know what our topic is, and we're just going to move on along, and Cindy will have an opportunity to more fully introduce herself when she takes over the slide deck. So the American Indian Health Commission was established in 1994, so 32 years. And this organization was established through the vision of tribal leaders here in the state and wanting to be on the front end in working with the state on issues that impacted tribes and Indian people in this state. So it's been based on tribal sovereignty and a tribally driven framework. The commission is a nonprofit organization, and that there are 29 federally recognized tribes that serve as delegates on the commission, along with 2 urban Indian health programs in the state. And I'm sure many of you are aware of this, but we like to repeat it. And then our mission really is to improve the health outcomes of American and Alaska Native people and to support tribal sovereignty, and improve the health and cultural well-being of our population through advocacy, through convening, and public education, facilitation, technical assistance, all of those types of activities. Our maternal infant health or maternal infant and child health work has long been in the works too. So we'll take you through a timeline in a minute, but our approach is developed on a comprehensive, long-term, tribally driven maternal and infant health strategy that relies on the wisdom and knowledge held by leadership and communities, both. It integrates healing and trauma-informed practices and acknowledges the impact of historical, genocidal, and ongoing racism experiences, and applies tribally developed tools such as the 7th generation and the Pulling Together for Wellness vision, values, principles, and frameworks. This is a timeline, and really the point of sharing this with you is to say that this work, it's very important that there's continuity in the work. There was an effort in 2008 where tribal leaders in the state agencies came together and actually funded some work. Long before that, tribal leaders were aware of the concerns around infant mortality in particular, but the poor outcomes, pregnancy outcomes, and health of moms and babies. And so there was very much a concern about these things long before we were funded to do this work. And you'll see that the commission has had continuous work since then, really since 2008 when we were funded, and this assessment work that we've been doing for the last several years is really an important part of this work. Our approach is based on the Pulling Together for Wellness framework. It's a culturally grounded policy, systems, and environmental change approach that serves as our guidance in strategy development and in our engagement practices. It focuses on restoring holistic health, symbolized by the medicine wheel, and a reflection that our physical, mental, emotional, and spiritual health are all interwoven in culture. And culture is central to parts of that holistic health and whole person, our community health, as well as the connection to our environmental surroundings. It's inclusive of both leadership and community engagement. We need both leaders, make certain there's continuity and the leadership that's necessary to carry it out through the tribal structures. Community engagement is really important because they know what's happening in the communities directly. They know what's effective and what's not. They know the stories. It embraces that 7th generation principle as a way of life, that we cannot just, move forward from where we are. We need to think about those ancestors like Billy Frank and the words that he shared in his great wisdom and carry those things forward in all of the work that we do. And we're very, very intentional about this. in thinking about the protection of our children, our babies, our moms, our elders too, right? The protection of our people, our population, and the environment in which we live. Our values that balance the native way of knowing. So we say native epistemology as well as Western science. That there's more and more validation of the importance of the native understanding, even from the aspect of those that are outside of native communities or native organizations. It stresses the importance of engaging with partners that understand and honor tribal sovereignty and self-determination as principal values. And Cindy, you take it over from here.
Thank you, Jan Marie. I guess the only thing, folks, that I would add to my introduction is just that on behalf of the commission, I have been a part of the State of Washington Maternal Mortality Review Board for about 8 years. And so just wanted to share that. So Jan Marie shared about the fact that the commission has really been involved in maternal and infant health for a long time. But the story of the addendum really began in 2019 with that second report that came out, the report to the legislature. And in that, it was stated that the highest risk factor for maternal mortality in the state of Washington is to be American Indian or Alaska Native. And you can imagine that's a very dramatic statement. And you can imagine how that rippled through communities. And I remember very clearly how people thought. They were very alarmed. They wanted to take action. And so that is how this project began. And it is very concerning that in the 2023 report and the 2025 report that these rates have been, they continue. Okay, next slide, Jen Marie, please. And so when we look at the data, and Annie shared and Deb shared some of this already, but we just wanted to show you again that the rate difference, the disparity in the rate. And as Deb's outlined very clearly with the CDC, the panels look at pregnancy-related death, and there is a big disparity there in purple. But we also have a real concern about the pregnancy-associated death, even though these are not deaths that the panel reviews. I mean, look at that green line. Why are American Indian, Alaska Native women dying at that rate comparison of high disparity in our state? You know, it is something that we are very concerned about. And another thing I want to point out is, you know, when Annie was presenting, you saw that some of the graphs said 2021, 2022. Well, this graph, when you look at it, it says 2014 to 2022. And this is really fantastic because when you're dealing with small populations like American Indian Alaska Natives, you know, Jan Marie and I both have white hair. We are elders, have been in this business for a long time. And we have been at so many national, state, regional conferences where American Indian Alaska Natives are not represented because of that small population. Well, the state of Washington is looking at these large data sets, these longer date periods, so that we can make those comparisons. And we are really grateful to them for doing that so that we can look and see the disparities. Okay, next slide, please. So when the 2019 report was released, as I said, it really got some attention. And the leadership of the American Indian Health Commission asked the state, well, what can we do to work together on this? And this was right before COVID. And so it took a little bit of time. But once some project funds were given to us, That was fantastic. Jamboree and I were super excited because it's been a long time dream of ours to go into community and talk to people about maternal infant health. But in the immediate post-COVID time, the tribes were still closed. So in phase one, we are breaking it up like this because in those 2 years, everything that we did had to be virtual. And we were quite nervous about that, about trying to engage with community members, not leadership, but community members via Zoom. Would people show up? But they did. And although our project was to hold at least one listening session, we ended up holding 5. We had 5 leadership sessions, which resulted in the 7 recommendations for the 2023 report. We got some continuation funding. And then finally, we were able to go into community and make those site visits and really be there to listen to people, to meet them, to do that relationship building, and to let them know that we are very interested in what they have to say in their ideas, their concerns, their issues, their solutions. And those 6 community visits resulted in 14 the recommendations that Jean-Marie will talk about in just a little bit. Okay, next slide, please. Jean-Marie talked about our strategy and the our approach, and this is why we want to talk about this. It's just really important for folks to remember that American Indian Alaska Natives are an oral tradition people. We don't have the history books, way back in the day, but we hold these things. So we hold these things in our minds, our memories, our hearts, our spirit. And so when we look at this, the root causes of maternal mortality and morbidity through our eyes, it's really important to just see that there is cause and effect. And so we look at these different examples of historical trauma, beginning with that depopulation, the forced removal, and what were the results of that? The loss of leadership, so many people died. There was a deep grief over that loss, the loss of family, the loss of homelands being moved to other places, which then, of course, disruption of relationships, etc. There's also intergenerational trauma. Many people know the stories of boarding schools now, the loss of generational cultural teachings. And I don't know if everybody knows that ceremonies and spiritual practices were outlawed. And so they actually had to pass a law about that, about the Freedom of Religion Act for American Indian Alaska Natives. But what were those effects? Well, deep grief, pain, and emotional damage, loss of those relationships between the land and our plant, animal, human relatives, the loss of traditional roles, and then resulting in that decline of cultural knowledge and guidance. And this isn't all history. This is happening today when we look at ongoing racism and discrimination. The termination policies of the 1950s. In the 1960s, the IHS Indian Health Service sterilization of American Indian Alaska Native women without their knowledge or consent, to modern times with the missing and murdered Indigenous women and people. And so that has resulted in physical health disparities and maternal morbidity issues of overweight, obesity, diabetes, and hypertension, mental health disparities and maternal morbidity issues such as stress, perinatal depression, opioid, fentanyl, alcohol, and tobacco misuse, and the self-medicating, which is what is resulting in what is happening now. And so these issues are really important to us. And now I'm going to hand it back to Jean-Marie.
These are the 7 recommendations that came out of the addendum from 2023. And first of all, is to reduce the disparity until it's eliminated, not 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 just move the needle, move it all the way to elimination. That that cultural appropriate engagement is important in the way that we work with American Indian, Alaska Native people and tribes in building that trust at the community level and at the leadership level too. Building trust is really critically important, and it takes time. You can't just operate in the old way that researchers did in extracting information and then never returning. That is not okay. And, people are really clear about it these days and articulating it. That trust building, there needs to be a great deal more effort there. And then that the data, it needs to be tribally led. These assessments need to be tribally led, the planning process, throughout the whole system, the planning, the implementation, the analysis. And that's including the PRAMS work that Cindy and I are doing on behalf of the American Indian Health Commission with others, that really is looking at addressing those root causes, again, that Cindy was talking about a moment ago, and to address historical inequities, and again, building that trust in a health system that's transformative. That is inclusive of making policy change and system change and actual allocation of funds to address the root causes, to improve and expand access for culturally relevant services and resources, and to fund, focus and prioritize support of tribally led workforce planning and development. We hear this all the way through from the youngest people to elders. It is important to have the workforce reflect them, and to support and fund tribally led nutrition planning and development, such as the food sovereignty work. Again, just thinking about certainly first foods, breastfeeding, but also the traditional foods. So I'm going to go through now the 14 recommendations. And first of all, upholding tribal sovereignty. And this is, this also has to do with the timing of where we are now. And tribal leaders felt it was really important to, just make certain that this is a priority, that it is understood that tribal sovereignty is the law of the land. It's foundational. Second is to prioritize, again, the elimination of maternal mortality and until the disparity is eliminated. To acknowledge the maternal mortality of American Indian, Alaska Native birthing people is a crisis, acknowledge it as a crisis, talk about it as a crisis, and address it as a crisis. To work with DOH to change the review process to include pregnancy-associated deaths for full examination in the review process by the MMRP. To continue efforts to facilitate discussions regarding MMR in each tribal community and urban Indian community. We've reached a portion of the communities, but every tribe and every tribal community is different. And it is important that we do that outreach work. To align with opioid fentanyl response task force efforts as they relate to maternal mortality and morbidity. And that work is actually in process now, to explore the development of maternal mental health, behavioral health aid and provider types, and maternal health support hotline. These are, recommendations, again, that came from multiple sources and have been actually talked about for some time. To continue investment in the people who experience the highest level of social determinants, the impact of social determinants of health, and the highest mortality rates that are most affected by discrimination. to support the implementation of the Pulling Together for Wellness framework at the tribal and the urban Indian health organization level, to support sustainable long-term implementation of the American Indian Alaska Native PRAMS survey that's under development, the state PRAMS survey, and the ACEs, Adverse Childhood Experiences Questionnaire, which we're also implementing, to assess provider training and education within state systems to understand gaps in knowledge base and in working with tribes and American Indian Alaska Native people, to utilize the assessment work. We call it MICA. It's the Maternal Child Health Block Grant Assessment, statewide assessment that there's also a report on the American Indian Health Commission's website that you can review on your own, and to continuously monitor the implications of recent federal actions and policy changes. And, that's a full-time job. And I know that you guys are, I'm sure, all up to your eyebrows in the same thing. But our focus is to be aware of those things that impact state and tribal funding, that affect our population's health and wellness. To support the Washington State Administered Pregnancy Risk Assessment Monitoring Survey, the PRAM survey that the state has historically done for many, many years, that has been disrupted during this time. That surveillance system is really important, and tribal leaders believe it's important, and we want that to continue. Now, I know we're at time now, and I'm wondering, maybe Cindy, could you just say a summary of the incredible progress that we've made?
Absolutely. And this is so great. One of the things about being on the panel is you just want to see action. And I really appreciate that Deb's also and Annie like to see what is the progress that we have made. So when we look at these 7 original recommendations, and a lot of them are going to be reflected here about reducing mortality until the disparities eliminated. And want to call out that not only are there tribal things that are going on at the tribal level, there are also a lot of good work that was going on with tribal and urban Indian grassroots organizations who are doing a lot of birth justice work in their communities. And the commission, Jan Marie, went through a lot of the things we're doing. We are working on this PRAM project, which we think is going to be very significant in understanding, just like our fishbone root causes. We need to just get that information out. The information that came out of the block grant was very incredible. I hope you do take time to go and read that. Our community conversations that informed the 2 addendums. We did that data gathering. We also have the MIH work group survey, which is talking about the needs and resource gaps in tribal and Indian communities. And we're also looking at, this is something from the National Indian Health Board funded by CDC. Will it make a difference to have some sort of tribally led maternal mortality review panel, whether it is from one extreme of a national tribal only to continuing with the state, some sort of state hybrid or state led. So there's a lot of information in there. And also, we recognize the importance of the work of WIC in dealing with maternal infant health in our tribal communities. And so I think, Jemry, if you go on to the next one, we'll just go through them real quick. So you see about the culturally appropriate engagement. Again, there's PRAMs, and we're also working on comprehensive strategies on how to go into community and build those relationships and build upon the networking and relationships that we have already. Okay, the next one, please. The data needs assessment. Again, we've already talked about all 3 of these things. A lot of work on data assessment. Okay, next slide. The inequities. So this one is really interesting, how we all work together, the urbans, the tribes, the commission, and the legislative and state agency partners to successfully pass the traditional Indian medicine bill, which has been really important. It's been passed in other states for reimbursement, and we really think that this is important in using some of our cultural practices and cultural medicines in healing our people. Okay, next one, please. What was 5? See, can you go back to 5? Expand access. So Jan Marie talked about the importance of the pulling together for wellness framework and the affiliated tribes, which is multiple tribes in the Northwest Territories. Past that, that is really significant. And there's also generational clarity training that is available through the commission, which Jan Marie leads. Okay, next slide, please. Number 6. Oh yeah, this is so great. What is happening again at the tribal and the regional and indigenous? So there are organizations such as Northwest Portland Area Indian Health Board, the Hummingbird Indigenous Family Services, and the Center for Indigenous Midwifery, who are doing community health aids, behavioral health aids with the Portland area, Indigenous doulas and lactation consultants, and community midwives and childbirth educators. So that is fantastic work, force development that's happening. And the last one, Jen Marie, about one of my favorite ones about the food sovereignty, that the tribal leaders just really recognize the critical importance of nutrient dense food for the moms and first foods for the babies. So really important. So thank you very much, Jen Marie. I think the last one's yours.
That is to go to the Commission's website. The 2 reports that we refer to are there on the site. There's a QR code here that will take you directly to the addendum, but also the addendum, of course, is attached to the link that Debs and Annie shared as well. So thank you so much for having us. We really appreciate it. And if there are others that have interest in our presentation, please send us an invite, because we want to spread this information far and wide. We need this support. We need your support. So just thank you again to the collaborative, and thank you, Debs and Annie. Such great partners. Just appreciate and love you guys so much.
Thank you, Cindy and Jan Marie. Jax, I think if I understand, we've got about 5 minutes where folks can either ask questions about either presentation or the group questions that I'm about to put back on the screen here. Basically about recommendations from either the main body of the report or the addendum that you might be working on or interested in working on and want to connect with other folks about, or you might want to be interested getting involved in somebody else's thing that they're starting or start something together. So if we can have a couple minutes just to open up either for questions or discussion about that, I just want to make sure people have a chance to highlight their work. And also, I just want to say if there's anybody else's work you know about and you want to plug. I see a hand there, Nicholas.
Yeah, so my particular area of interest is working with fathers in the perinatal period, prenatal to 3, and I have some ideas about what I might be able to contribute towards the maternal mortality recommendations, but I'm not sure who I would talk to about that. And I'm just wondering if either Debs or Annie, if I could reach out to either or both of you just to maybe have a conversation to see if there is something that would be aligned.
Are you working with the Fatherhood Council at all? Because we actually did a presentation for them.
I am on the council,
Oh, you're on the
yes.
council. Okay, got it. Yeah, I know I did a presentation for them, and there was some great conversation actually when we asked a version of these questions in that group where folks started connecting about some of the ways they might want to work together. Um, but yeah, we'd be happy to follow up about that too.
And am I best to reach out to either one of you?
Yeah, sure.
Great, thank you.
Yeah. And I know folks in this group might want to connect with each other or let each other know about something that you're doing. Or anything you've recently written or done that you'd like to highlight.
Well, if there are no questions, I just want to express my deep well of gratitude and cheers and congratulations to you for, I know that you represent a incredibly large and like highly skilled and talented group of folks. And I'm just so grateful for you for Jan Marie, Deb, Cindy, and Annie for being here today and presenting this incredible work. You are saving lives and leading the way in how to do this work humbly and phenomenally. And I feel very grateful that you've given us your time today to be here and support us in Pierce County to be able to do our work better. And I trust that even though folks aren't maybe using this space to talk, these questions are going to stimulate a lot of internal thinking and interagency thinking. Um, and you are having such an incredible impact. So thank you so much.
Thank you.
Thank you.
We have one more presentation, which I feel like really is a beautiful connection here because so we need to make sure that when families and individuals need support, that they can get connected to that support. And Elevate Health, our accountable community of health in Pierce County, is here. And Johanna, I'm going to ask that you bring up the slides again, please. And I'm going to introduce Heather from Elevate Health to talk about Pierce County's Connect Pierce Community Resource Hub.
Did you want me to present the slides for Elevate Health?
Yeah, that'd be great.
Okay.
Okay, well, hi, I'm Heather Thine. It looks like my my camera just froze. Oh, there I go. Okay, my name is Heather Thine. I use she, her pronouns. I'm the Senior Manager of Community Clinical Linkages at Elevate Health, which is Pierce County's accountable community of health. I've been with Elevate about 3 years now. Prior to that, I was a social worker, and one of the populations I worked primarily with were pregnant people undergoing or going through opiate use disorder. And also seeking recovery or in recovery. So this is an issue that is very near and dear to my heart, maternal health. I also have a colleague with me today, Lorene, and I would love to give Lorene a chance to introduce herself and talk a little bit about what she does with me, with Connect Pierce and with Elevate Health. Lorene, please go ahead.
Thank you, Heather. Hi, everybody. Appreciate the invitation to present today. I am Lorene Tomich, and I serve as the Social Care Network Manager for Elevate Health. And at Elevate, we are collaborating with cross-sector partners to transform how our systems work together to support the health and well-being of our community. And we feel that Pierce County really has an incredible network of partners already, a lot of organizations doing fantastic work. And our goal is to really take that informal social care connection that already exists in our county and work it into and strengthen it into a more coordinated and sustainable network. And of course, this includes our government partners, our tribal partners, our healthcare providers, behavioral health organizations, and our social service agencies and community members at large. And at the center of this effort of our social care network is our community care hub, which we call Connect Pierce, which coordinates support for people who need it from all these different entities. So um, we're excited to share about this, and I'm going to pass it back to Heather, and we're happy to take questions at the end.
Thank you, Lorraine. I am used to driving this presentation, Joanna. Thank you so much for helping me today. I will do my best to not be a frustrating navigator. Okay, so to begin with, just to introduce you a little bit to Elevate Health, as I said, we are Pierce County's accountable community of health, which I'll talk a little bit about later. But we are a community-driven nonprofit collaborative. So the whole driving force behind Elevate Health is to bring people together to the table across sectors to try to better health outcomes for people. That's really at the root of what we do. So we work across those different sectors to foster collaboration, join the resources together at the table, and create that positive change, hopefully at the system level. You can go ahead, Joanna, and I hope I'm saying your name right. Next slide. Thank you. So we are Pierce County's accountable community of health, and ACHs are independent regional organizations that work together with their communities on healthcare services to improve health-related social needs. So we talked a little bit today. Others talked about social determinants of health, which means where you're born, whom you're born to, at what time you're born. All these kinds of different factors influence what kind of health outcomes you experience. Well, in our work, we address health-related social needs, and those two things are very closely linked. So those health-related social needs are really addressing all those social determinants of health that might not be so positive. So this is the work that drives ACHs, is to address those health-related social needs for better health outcomes in individuals and in populations. Next slide, please. So we are funded through the Medicaid Transformation Waiver. I see some familiar faces in the crowd, and you're probably well acquainted with this waiver, but this is a waiver through the Center for Medicaid and Medicare Services that then gets passed down to the Healthcare Authority in Washington, who then funds our work on the 1115 Medicaid Transformation Waiver. So to just give you a very small nutshell idea of what this waiver focuses on, basically, the federal government said, here we have all these health disparities that the system has created that are perpetuating in the system. How do we mitigate these? And what they saw in the evidence was that community-based care is really at the root of the solutions for all of these disparities. In solidifying, in investing in communities, in strengthening communities, and utilizing that special care that only communities can provide, we're going to see better outcomes for people rather than the system that we have in operation right now. So that is the work of the Medicaid Transformation Waiver. Next slide, please. So again, just to differentiate, Elevate Health is Pierce County's accountable community of health. We are the backbone organization, and Connect Pierce is our community care hub. Next slide, please. Next slide, please. So this is how it works. It is a free community care hub that helps individuals and families across Pierce County access the health and social services they need to thrive. So this is 100% free. There's no hidden fees. There's no billing your insurance or anybody's insurance. It doesn't matter if you're insured or not or what kind of insurance you have. Everyone in Pierce County can access care through our hub. Please go to the next slide. And so the idea behind a community care hub, and like, why would we create a community care hub? And I think the main thing that community care hubs offer is a centralized point of referral. So folks who come to our hub are linked with a helper who then walks them through the systems, walks them through the appointments, the services and resources that they need in order to address those health-related social needs. So instead of a person who's maybe isolated, doesn't know how the systems work, doesn't know what's available here in Pierce County, it's instead of that person having to make 25 different phone calls to try to address one need, let's say, they make one phone call to our community care hub. They get linked with a qualified, knowledgeable provider in the community who can then walk them through the process of navigating all these systems to get the services and resources that they need. We also provide access to a diverse network of providers. So fortunately in Pierce County, we have a wonderful network of helpers and people doing great work. And so we provide access to that network of providers. Next slide, please. So I went over this a little bit, who's eligible. It's anybody in Pierce County can access this community care hub for free. And we are happy to help them with those health-related social needs. Next slide, please. So this is how it works, if you're wondering how it works. So that first step is the referral step, and we get referrals in a few different ways. First of all, we're networked with, or contracted rather, with 28 network partners, community-based organizations in Pierce County. And those folks, of course, are serving folks in Pierce County themselves, so they bring clients into our hub that way. Then we have a statewide call center that anybody in Washington State can call and get routed to their community care hub. Folks from Pierce County, of course, will be routed to us. And then we will get their information through a secure system and go about assigning them that way. Or the third option is we have a referral form on our website. Our website is www.elevatehealth.org. And right on the front page of that website, you will see a button in the upper right-hand corner that says Make a Referral. And anybody who would like services through the hub can fill out that form for themselves, or they can have somebody fill it out on behalf of them. So if they're working with another organization and want to go through our hub, they can go through that form as well. So those are the three ways that we get clients into our hub. Now, once we get that client's information, our team goes about reviewing their information and trying to make a great one-to-one match between that person and their personal helper, who we call community-based workers, but you've probably heard them referred to as community health workers as well. Community-based worker is just the term that we use to honor the fact that these workers come from many different titles and walks of work. So that can include doulas, promaturas, peers, case managers, all different titles. They're all community-based workers. So this team is going to look at this person's information and say, okay, well, where geographically are they in Pierce County? What age group do they come from? What sociolinguistic group do they come from? Cultural appropriateness and cultural humble care is critical to this network. It is the reason that we designed our network the way that we did, was because we understand that, for instance, we're talking about Indigenous mothers today, and we're acknowledging that systemic disparities, racism, a long history of trauma and oppression and savagery toward Native Americans has impacted people even today. It is ongoing, it is continuing. So for instance, if we have an Indigenous mother who maybe wants care, do they trust the system that is available to give them care? Do they trust the people who are available to help them? Do they trust, is the care that they're receiving honoring their personal culture, their people's culture, the way that they want to experience pregnancy, all of these things. So we look at all of these different factors and we say, who in our network is best equipped to help this particular person? And so we really try to go about that carefully in assigning that person their helper. So once their helper is assigned, we get to step 3, and that's the connection piece. So within 48 business hours of that assignment, the community-based worker is going to reach out to the person. They're going to explain about the program, explain about what working together will look like. And then once they have that person's consent, they're going to proceed on to step 4, and that's the working relationship and the actual care coordination. So care coordination is a very close navigation relationship. You have the CBW as the guide, and then you have the person who needs the services and resources. And so that guide, that community-based worker, is really the pathway to all of the services and resources that are available in Pierce County. So that community-based worker, regardless of where they might be employed, they're going to work together with that person in a trauma-informed, person-centered way to get them connected with other helpers in the community. So we talk a lot about it takes a village to raise a child. This is what we're talking about. This is the potential creation of that village. This potentially a pregnant person, needs some help, they come through our hub, they get connected with their helper, and then that helper finds them other helpers to work with. So that's the creation of the village and the social support that is so, so critical to health. So our care coordinators work with folks on average between 4 to 9 months, but they can go longer than that. So conceivably, you could have somebody working together as a guide and a navigator and a support to a pregnant person for the entire duration of their pregnancy. And in that, I think it's about 3-month postpartum period that is a really critical period for health issues like thrombotic embolisms and things like that happen after pregnancy. You can have a helper from the start of the pregnancy to the end of the pregnancy and postpartum if that's what that person needs. So I'm just going to stop there. I guess we're going to ask questions later. So next slide, please. So this is just a map to show the locations of our participants served. And you can see over in that upper left corner, you can see Key Peninsula, and we see little dots there. We see dots near Graham and Eatonville and Roy. The wonderful thing about community-based workers is that they are a mobile workforce. So where there might be limitations for a person who lives in Eatonville, for instance, in accessing services, the community-based worker can meet them where they are and again, act as a guide and an entrance point to all those services in Pierce County for that person in the rural community. And of course, we love that we're tapping into our rural communities because we've had a little discussion today about the kind of health outcomes that rural communities see, and we want to mitigate those as well and work together with our community partners to bring about better outcomes for those folks. Next slide, please. So if you're wondering, if you're thinking about how can I utilize this, who can I refer? The main critical factor is that they have a health-related social need. That's the main thing. There's really no eligibility criteria for this except that they live in Pierce County. And I'm here to tell you too that there is a community care hub in every region of Washington. So even if you have a client who perhaps is residing in King County, I can connect you with the King County Community Care Hub, which is run by Healthier Here, and they can get services through them. So there are services available across Washington state. But that first criteria that they have a health-related social need, that's the most important thing. But it's really anybody who needs assistance with navigating systems. Perhaps they're a recent arrival to Washington. They don't know how things work. That's a perfect candidate for this hub. But really anybody who needs help and needs help navigating these systems and needs help with their basic needs and getting to a point of thriving, not just surviving. Next slide, please. In terms of if you're wondering if there's anybody you shouldn't refer, it's really anybody in an active medical or behavioral health crisis. We're not a crisis team, so they can't go out there 24/7 or anything like that. So please make sure you're accessing emergency services for those folks. And then, of course, the really obvious one is that folks who don't consent or are unwilling to participate can't participate in the hub. And then next slide, please. Next slide, please. Sorry, I might have to skip through a few. And next slide, please. So this is an image of all of our partners right now. These are our 27 community-based organizations with whom we are partnered. These are the folks who employ our community-based workers, and then the community-based workers refer out to everybody in Pierce County that can meet their clients' needs. So we're not limited just by this network or the resources available in this network. We consider all of the social care providers in Pierce County to be our partners. So that is the end of our presentation. Thank you so much, and I'm happy to answer any questions. I can see that there are a few in the chat.
Thank you so much, Heather and Lorene. We can take one question because we're at time, and the question is, what's the criteria or qualifications to be a community-based worker?
That's a great question. And the answer to this question might surprise some folks is that in Washington state, community-based workers are an unlicensed body of workers. So there's no community-based worker certification. So that's why there are so many titles. So we have some community-based workers who are peers. They've gone through peer training. or case management. Maybe they have an associate's degree in behavioral health or social services or things like that. And then they become a community-based worker, but it's really an assumption of a role. It's a willingness to help people and to work together with an organization who can train them through really an apprenticeship, I guess is what I would call it. So I would say probably going through some programming, maybe an associate's course in health and human services would be helpful to you if somebody wanted to be a community-based worker, but it can be really anybody because we have community-based workers who have a high school degree, and we have those who have a bachelor's degree working toward a master's. So the answer is, do you have a willingness to help and a heart to help? If so, you can be a community-based worker.
Thank you so much for presenting today. Thank you to all of our presenters again. Thank you, Johanna, for running the slides in the background. We appreciate you all. Please reach out to us. Our next meeting is on June 8th. And we would love you all to continue to return. We will send out announcements about what you can anticipate, and then we'll have a conference in October after then. Thank you all. Have a great day.